بسم الله الرحمن الرحيم. أولادي وبناتي الأعزاء، الحمد لله على السلامة، ونعتذر منكم بسبب هذه الظروف، وربما كما يقال رب ضارة نافعة. احنا وانتم ربما تعلمنا شلون ندرس بالتعليم الإلكتروني. محاضرتنا اليوم our lecture today is about the oral cavity and the pharynx. We start in the anatomy of the oral cavity. The boundaries of the oral cavity start from the vermilion border of the lip to the junction of the hard and soft palate, anterior tonsillar pillars, and the circumvallate papillae. The subunits of the oral cavity include the lip, the buccal mucosa, upper and lower alveolar ridges, retromolar trigon, oral tongue, which is the anterior two-thirds of the tongue, which is anterior to the circumvallate papillae, hard palate, and the floor of the mouth. We go to this picture, which is very important for us regarding the pharynx and also the oral cavity. When we see the borders and the contents of the oral cavity, as you see, this is the anterior part of the oral cavity, the lip. This is the hard palate. This is the soft palate. This is the anterior tonsillar pillar. This is the circumvallate papillae. These are the posterior limits of the oral cavity. This is the oral cavity. This picture is very important not only for the oral cavity but also the pharynx and its subdivisions. See, this is in the next lecture and lectures. This is the oropharynx and its contents. See, this is the oropharynx. Above the oropharynx is the nasopharynx, and below is the hypopharynx. When we go to the pharynx, which is a tubular structure about 13 centimeters long that extends from the base of the skull to the esophagus, and it's situated immediately in the front of the cervical vertebra. The pharynx serves as a passageway for the respiratory and digestive tracts and changes shape to allow the formation of various vowel sounds. The pharynx composed of muscles and is lined with mucous membrane, and it's divided, as I said in the past picture, to the nasopharynx, oropharynx, and hypopharynx. Also, when you see here, we can see the Eustachian tube. This is the Eustachian tube. This is the Eustachian tube. It contains the opening of auditory tubes, the opening of the two posterior nares, and the opening of the larynx and the opening to the esophagus. Here, under, this is the nasopharynx. This, as I said, second tubes, and this is the entrance of the larynx. You see, this is the epiglottis. This is the limits here. The limits, this is the valleculae, the contents of the oropharynx. Now we will speak about it. The oropharynx begins anterior of the circumvallate papillae, tonsillar pillars, and the junction between the hard and the soft palate. The oropharynx extends vertically from the inferior surface of the soft palate superiorly to the plane of the superior surface of the hyoid bone. The oropharynx is divided into 6 subunits or subsites, which include the base of the tongue, soft palate and uvula, palatine arch including tonsillar fossa and pillars, valleculae, and the lateral and posterior oropharyngeal walls. The hypopharynx, or we call it laryngopharynx, the vertical limits of the hypopharynx are the superior border of the hyoid bone and the lower border of cricoid cartilage. It is divided into 3 subsites: piriform sinus, or fossa, or we call it laryngopharyngeal sulcus, left and right one, hypopharyngeal walls, also lateral and posterior, and the postcricoid region. This is the area of pharyngoesophageal junction. The postcricoid area extends from the arytenoid cartilage to the inferior aspect of the cricoid. This watershed area connects the 2 piriform sinuses, thus forming the anterior wall of the hypopharynx. When we go to the nasopharynx, the posterior quoin form the anterior limit of the nasopharynx. The nasopharynx is divided into 3 subsites: the lateral walls, including the fossa of Rosenmüller and torus tuberous, as I said in the picture, vault, including the superior surface of the soft palate, and posterior superior wall extending laterally from the vault to the base of the skull, including the adenoids. When we return back to the picture, this is the nasopharynx. The quena we cannot see because of this wall. This is the vault of soft palate. This is the Eustachian tube. This is the adenoid. This is the wall. This is the posterior wall. So this is from here is above the oropharynx is the nasopharynx. Now we go to major salivary glands and their ducts. The major salivary glands include parotid, submandibular, or we call submaxillary, and the sublingual glands. Really, I don't want to speak too much about the anatomy and function and the other characteristics of the or features of the glands. This is maybe discussed by general surgery, but the most important for us, the ducts of these salivary or major salivary glands, which is very important for us for the ENTist. The parotid, or we call it Stenson duct, orifice is lateral to the upper second molars. The submandibular or submaxillary, or we call it Wharton's duct, orifice is in the midline floor of the mouth adjacent to lingual frenulum. حقيقة sometimes انتم ممكن لما ترجعون للبيت تقدر تحاول ترفع لسانك لفوق وتشوف the frenulum there is small opening and you when press لما تضغط تحت الفك شوف انه الفلويد يطلع لك من ذني الفتحات. ممكن لما ترجعون للبيت تجربونه. The third one is the sublingual, or we call it ravenous ducts. Multiple orifices draining into the floor of the mouth or into the submaxillary duct. Now we go to another structure which is a very important structure in the oral cavity, which is the tongue. The tongue is a muscular organ. The anterior 2/3 is covered by papillae, including filiform, where there is no taste function, and fungiform, diffuse, and foliate. It is in the lateral part of the tongue. The circumvallate papillae are large and lie in a V-shaped at the junction of anterior and posterior portions of the tongue. حقيقة بالنسبة للسيركمفاليت بابلي مجرد أذكركم بهالمحاضرة كثير من الناس لما يشوف خاصة إذا كان large بابلي he is afraid, he thinks that this is a disease. حقيقة كثير من الأحيان نحاول نقنع المريض إنه ترى هاي المسألة طبيعية وأنتم ترجعون ممكن أي واحد من عندكم لما يرجع البيت ويطلع لسانه بكل قوة he can see the circumvallate papilla. The muscles of the tongue are extrinsic muscles which include genioglossus, hyoglossus, styloglossus, and palatoglossus, while the intrinsic muscles are superior and inferior, longitudinal, vertical, and the transverse. Now we go to the sensory innervation of the tongue. Anterior 2/3, the oral tongue, we call it, sensations of the touch, pain, temperature, transmitted via lingual nerve V3. Taste sensation is transmitted via lingual nerve to chorda tympani, while posterior third, which we call tongue base, touch and gag, which is visceral afferent sensation, is transmitted via cranial nerve 9 to the nucleus solitarius. Taste sensation from circumvallate papillae and the mucosa of epiglottis and valleculae to the nucleus solitarius of the bones via cranial nerve number 9. The vascular supply of the tongue is from lingual artery, which is the second branch of the external carotid artery, and drained via the lingual vein. Saliva of the mouth, about the total saliva is about, in average, is about 1,500 ml per day. 99.5% of saliva is water, with only 0.5% organic and inorganic solids. Now we go to another very important subject, which is or concerning in the lymphatic system. The lymphatic system in this area is very important. We call it the Waldeyer's ring or internal Waldeyer's ring. Together, the lingual tonsils anteriorly, the palatine tonsils laterally, and the pharyngeal tonsils, which we call adenoids posterior superiorly, form a ring of lymphoid or adenoid tissue around the upper part of the pharynx, which is known as Waldier's tonsillar ring. All the structures of the Waldier's ring have similar histology and presumably functions. Palatine tonsils composed of lymphoid tissue with germinal center containing 6 to 20 epithelial-lined crypts. There is capsule cover or over the deep surface separated from the superior constrictor muscle by thin areolar tissue. The palatine tonsil is contiguous with the lymphoid tissue of the tongue base, which we call it lingual tonsil. احنا صراحة لما نسوي ادينو او تونسيلكتومي نسوي دايسكشن للبالاتاين تونسل نكون مستمرين حتى we remove the lymphoid tissue of the tongue. The arterial supply or blood supply to the tonsil, the main arterial supply is from tonsillar branch from facial artery. حقيقة هناك another branch لكن أنا ما حبيت أذكرها لكم حتى ما نعقد الموضوع عليكم. While the venous blood supply is by the lingual vein. Now we go to the disorders of the oral cavity and the pharynx. We start in the disorders of the oral cavity. Inflammation of the oral mucosa. Stomatitis is the general term for any inflammatory disorder of the oral mucosa. It can be associated with the following diseases. Gingivitis, a condition in which the free gingival margins close to the teeth are red, swollen, usually painless and bleeding. الحقيقة سواء كان هذه أو البيريودونتايتس هي غالبا تروح احنا نشوفها دائما لما نفحص المريض ولكن هي تروح على طبيب الأسنان الدنتست هو اللي يتولاها. Periodontitis, inflammation of the periodontium, which includes the periodontal ligament, the gingiva and the alveolar bone. Another problem which is acute necrotizing ulcerative gingivitis, ANOG, or we call it Vincent angina, or we call it trench mouth, which is due to synergistic mixed anaerobic infection including Borrelia vincenti, fusiform bacillus. The condition has an acute onset with necrosis and ulceration of the gums. Symptoms are pain, fetid odor to the breath, excessive salivation, and bleeding gingiva. Treatment is oral hygiene, analgesics, and antibiotics. Then we go to a very common problem, and I think most of you exposed to this problem, which is herpetic gingivostomatitis and herpes labialis, are usually due to human herpes simplex virus type 1 and rarely due to type 2, which always causes herpes genitals. Herpes labialis is the most common viral infection of the mouth. The primary herpes labialis develops approximately 5 to 7 days subsequent to contact with an infected person. A prodrome lasting up to 4 to 8 hours and can be characterized by focal mucosal tenderness and erythema quickly followed by evidence of group of small vesicles over the oral mucosa. Such vesicles are thin-walled, delicate, and short-lived. An inflammatory periphery surrounds each vesicle, followed by the development of shallow, painful, and discrete superficial ulcerations. The duration of the entire process ranges from 7 to 14 days with a generally self-limiting course. The treatment is generally to be symptomatic and supportive in nature as the patient develops antibodies to the infectious agent. احنا طبعا هذا فايرال وحقيقه الناس دائما انتبايوتيك وهاي احنا مشكلتنا وهي الانتبايوتيك الناس شبعوا انتبايوتيك من هاي الاشياء البسيطه اللي هي self limiting. This is the herpes labialis and this is the stomatitis اللي هو gingivitis or gingivostomatitis. طبعا the gingivitis or stomatitis affecting the ulcerative can affect the tongue, the oral, or the mucosa of the oral cavity. Thrush, or we call it the candidiasis of the tissues of the mouth. The condition is characterized by the appearance of creamy white patches of exudate on an inflamed tongue or oral mucosa. It is usually a benign condition in normal children, but may be a sign of AIDS in young adults, in the elderly, or in patients who are using inhaled steroids or patients who have received radiation and have decreased salivary gland output. Topical or systemic therapy may be used for treatment. Biogenic granuloma, a small non-malignant mass of excessive granuloma tissue, usually found at the site of an injury, most often a dull red color and bleeds easily. When forms on gingiva, we term it or we call it ebulis. Mucositis commonly encountered as a result of chemotherapy or radiation therapy. Now we go to non-infectious lesions. Also, this is a very, very common lesion. Recurrent aphthous stomatitis or recurrent aphthous ulcers, or we call it Soton disease, represent the most common non-traumatic form of oral ulceration with an incidence range between 20% to 40% of population. This remains an incompletely understood mucosal disease, chiefly affecting the oral and oropharyngeal mucosa and less commonly the genital mucosa. Of note are data indicating a general prevalence among those in professional groups, those of higher socioeconomic status and non-smokers. حقيقة شافوها انه بالناس المتعلمين اللي هم او بالهاي socioeconomic status and non-smokers، ربما هذول معرضين اكثر لحد الان ما معروفه بالضبط هل بسبب الستراس thinking يعني التفكير او الانشغال بالامور العلميه والحياتيه هو اللي يكون they are more exposed for this common problem. The predisposing factors are stress, sometimes we call it stress ulcer, hormonal alterations, nutritional deficiencies, B12, folate, iron, food allergies like nuts, chocolate, gluten, and immunologic abnormalities. Treatment: mild and infrequent episodes of minor Aphthous ulcers generally require little more than symptomatic management. When treatment is necessary, the general mainstay is the use of topical steroids. When lesions are severe or occur as a continuous series of outbreaks, short-term systemic steroids are effective. Behçet's disease, oral ulcerations, conjunctivitis, iritis, and urethritis, and sometimes associated with sensory neural hearing loss. Other oral cavity lesions, leukoplakia, white plaque from its name, a white hyperkeratotic lesion that may or may not be associated with dysplastic change or on histologic examination. It occurs most frequently on the lip, vermilion, buccal mucosa, mandibular gingiva, tongue, and floor of the mouth. Less than 10% of cases will demonstrate carcinoma or severe dysplasia on biopsy. The second is erythroplakia or red plague, a granular erythematous area often encountered in association with erythroplakia. About 50% will demonstrate severe dysplasia or carcinoma in situ on biopsy. The third one is the hairy tongue. It is due to hyperplasia of filiform papillae. It may be black, blue, brown, or white depending on microflora and nicotine staining, and it is often associated with candida overgrowth. It is asymptomatic, but for its appearance. Treatment is by mechanical brushing or scraping of the dorsum of the tongue. شوفوا this condition, the hairy tongue، لما يشوفوها الناس شقد انه يخافون وحقيقه يزيدون الطين بله لما ياخذون انتبايوتيك او مضمضه او ما شابه ذلك، بينما this condition a self limiting، تقدر انه تستخدم فرشه اسنان من نوع السوفت وتحاول بمعجون الاسنان تحاول يعني تسوي لها brushing و with time ممكن تتخلص من عندها. See, this is the hairy tongue. Another condition is the ranula, a mucocele of the sublingual gland that presents in the floor of the mouth. If it penetrates the mylohyoid muscle and presents as a soft submental neck mass, it is termed a blanging ranula. Treatment is excision of the entire sublingual gland in order to prevent recurrence. Torus palatini, a benign excessive bone growth in midline of palate that continues to enlarge beyond puberty. Occasionally, it must be removed in order to prevent denture irrigation or dental rotation. Geographic tongue, irregularly shaped areas of depapillation occur over the dorsum of the tongue. The patches vary in size and distribution over a period of days, and it affects 1% of the population. No treatment is needed. Also, this is a very common، وأيضا بالنسبة للناس يخافون من عندها وياخذون غرارة وياخذون انتبايوتيك وقسم عندهم خايفين يتصور انه ورم، بينما هي حقيقة ما تحتاج إلى أي علاج. Now we finished our lecture today. If there is any comments on this, you can send a message. ممكن إذا عنده أي واحد سؤال، أي سؤال ممكن يسأله على المحاضرة، ممكن إنه على جوجل كلاس روم، أو يراسلني مراسلة إذا عنده تليفون، أحد يعني عنده تليفون أو واتس أو أي شيء، أنا حاضر. والسلام عليكم ورحمة الله وبركاته.